Okay. Oh, and it's like generating a transcript on the side. So, okay. So I'm going to share the screen and we'll pick up on what we did Monday. Okay. I think you can see my entire screen, so that's fine. Sorry. I completely shut out. So can you all see? You probably can see like everything, right? Like the slides are on the side.
Wait, I can't see it.
Oh, you can't? Okay.
No.
No, there's like
Because I'm sharing a window. Oh, shoot. What the heck? Okay, it's still recording, but okay. How about now?
Yeah,
we can see them.
we can see it now.
Okay, perfect. So we're gonna skip through all of this stuff. I also cannot see you guys again in the side, so if you just, like you just did, speak up if you want me to stop. So we started off last week just talking about what is abnormal psychology and defining what abnormality means. And we talked a lot about the different features we're talking about when we want to say that behavior or feelings or thoughts that someone has might be concerning enough for us to consider referral for like treatment or an assessment because it might indicate they have some mental health problems. So we talked about atypicality, harmfulness, and being developmentally inappropriate. Um, that's the way your book talks about it. The other slide I put up was just in general. Another way you can keep it in your mind is the 4Ds. So dysfunction, distress, deviance, and dangerousness. So keeping that in mind as we move forward, especially when we do more case vignettes for different disorders, because you'll want to ask yourself, is this behavior or this constellation of symptoms, does it look like it's causing this person dysfunction, distress? Is it deviant, meaning does it deviate from the norm? And then is it dangerous at all for this person or the people around them? So because of that, we also ended, I think we ended here on egosyntonic and ego-dystonic. And we talked about how the whole idea of there being distress, sometimes we can think of distress as being egosyntonic when it's um, more aligned with that person's values or who they are or what they want for themselves. And so it may not be causing distress, in which case it is syntonic. You think of it as having synthesis with that person. Whereas being ego dystonic means it does not line, it's different from what they wish they were like, what they want to be like. Whether or not those are their values. And so that does cause distress because it's incompatible with what they actually care about. So we gave the example of OCD and then this picture of Ted Bundy. So we ended there. Any questions before we talk about prevalence rates and kind of what contributes the different prevalence rates? Okay. Oh, I think you said no. Okay. So let's talk a little bit about how common mental health problems are, or just more specifically, when you're getting a diagnosis is in youth. So in general, we have a lot of different numbers, whether that's children, teens, or young adults. And that's just because it might vary based on who is reporting the child for referral. So it could be either self-report or informant report. And so if you're seeing, it's not often that you're going to get a kid who self-refers themselves. So it's pretty unlikely you're going to have self-report or self-referred kids to therapy, whereas you'll probably get referrals from the teachers or from the parents. And so, for example, when we are doing like an assessment of a kid, let's say maybe they are 10 years old and we're screening them for depression because they're 10 and they theoretically can read, they can write, they understand this survey that we're going to give them. We might give them a self-report version of a depression screener, and we are also going to give it to their parent. And so we'll have two forms of report. And a lot of times there's a lot of discrepancy between the person who filled out the screener and then the actual person who is reporting on themselves. So there's a survey called the Child Behavior Checklist, the CBCL, and it covers like a lot of internalizing problems like depression, anxiety. I think it taps into like OC, like obsessive compulsive type behaviors, and then a lot of externalizing. So those are things like aggression, conduct problems, and then like peer support, and then some other things. And so a lot of times you'll see, I don't know, I've given it to like little kids before, like 8, 9, and they'll say, no, I don't feel sad. No, I don't wet the bed. No, I don't have a hard time making friends. And you compare that to the parent report, and the parent might say, yeah, it seems like my child's really moody all the time. It seems like they have a really hard time making friends. Occasionally they wet the bed. And so you can see that that is more endorsement of the different symptoms. So from that report, the parent's report, we're probably going to see the kid moving closer to a diagnosis or meeting the threshold for a particular mental health problem. So that contributes to whether or not we have high or low or similar rates across populations, because we want to consider who's actually reporting on the mental health problems. The other thing is the characteristic of the population. So how old are they? What's the gender? And then where are we pulling these people from? So is it a clinical sample or community? So the age thing is what I just said. So adolescents, teens are probably much more likely to be able to self-report on themselves. There's a lot more insight. There's some reflection. Teens may be the ones who are referring themselves. The teen might be the one saying, "Hey, mom, I've been really moody. Like, I'm, I want to hurt myself. Like, I need help." So that might be the teen referring themselves, in which case they probably do have a lot of insight. And so you might see more accurate or maybe higher endorsements or lower, but it seems that it might be more accurate to the person. Versus if you have a little kid, let's say a 5-year-old, we are going to take their self-report into consideration, but in that case, it's probably more likely that you're going to place more weight on the informant report. So I might care a little bit more about what the parent is seeing because they're an adult, they have more insight, they observe their kid across different like settings. And then the other one, gender. So the kid might have lower insight, and so they might be reporting less. Or maybe they don't know that that's something they're experiencing, and so they are saying, no, I don't have that problem. For gender, it's kind of what we talked about last week or Monday. So differences in rates based on maybe gender norms, gender stereotypes. And so that impacts a lot who gets referred to treatment. So if you have in your culture or in your society expectations about males supposed to be acting one way, and they're acting in alignment with that thing that you've set for themselves, um, you may not see that they're going to be referred for treatment, or maybe people don't have as much of a concern because it's consistent with what they think boys are supposed to do. Whereas if you see a young girl start doing it, maybe that does raise a concern in that culture. And in that case, they do refer the person to treatment or to get assessed. And so in that case, gender norms become a role here because it impacts who gets referred. It also impacts the way that they're reporting what their symptoms are. So again, if you have a 17-year-old male and a 17-year-old female, and you're taking into consideration like the gender stereotypes, gender norms, it might be the case, I'm not saying this is always the case, but it might be the case that males might underreport their internalizing symptoms. So less likely to report feeling down or feeling anxious because of some stereotypes in our culture in general in the US about should males experience this, or should they be able to manage it, which is not fair, right? It's neither here nor there. That just impacts how people are referred for treatment. So, and then whether or not they're actually endorsing symptoms. So that's another reason we have some disparities across the different rates that you'll see. So if you look up what are the mental health problems in the US, you'll get one number here, and you might get another number here. And so that's what the difference is. And then clinical versus community. So where are you getting your people that you're asking do you have mental health problems? So if you're sampling people who are already an inpatient, let's say they're in the hospital, let's say it's severe enough that they need to be hospitalized or in a residential setting, because they've already hit that threshold of needing so much care and needing so much supervision, and maybe they need physicians at their care pretty frequently, it makes a lot of sense that you're going to have higher rates of mental health problems in this clinical sample, because they're getting treatment already for clinical health or mental health problems. Whereas if you're sampling people from the community, that's just everyone out there. And so you're probably going to have a little bit more variability. You'll have some people say, yeah, I have a lot of mental health problems. And we might say, ooh, that person needs to be in the clinical sample. They need to be referred. And you also are going to have people who say, no, I feel totally fine. Like none of that explains me. I don't have any of those symptoms. So in that case, your community sample, you're going to have a lot more variability. You'll have people with mental health problems, whether it's low or high level of need. And then you'll have people who say, no, nothing at all. And so again, if you're in that community sample, your rates might change versus your clinical sample, which could be much higher. Okay, any questions about variability across disorders, just in general? Okay, I'm gonna skip the some data part. It's just a couple of different numbers that have been out there. But I think importantly, in a given year, 1 in 5 kids meet criteria for an emotional or behavioral disorder in the US, which is actually quite like a lot. And so I think it's a really nice thing that you're all taking just psychology in general and for this course, like focusing on kids, because thinking about people or little kids maybe in your life that you know, 1 in 5 cousins, let's say, will experience anxiety or depression or maybe have ADHD or something like that. And so that's actually a pretty high rate, which means it's really important to be able to capture those kids early on when they start to experience certain problems and then be able to treat earlier on. That way they're not going the rest of their life feeling these things. It doesn't worsen and it's kind of more manageable and maybe it goes away. So that's an important fact. This part, I will say, I think the only thing I want you to take away from here is identification is important. So in general, when we're studying kids, I think there has traditionally been a lot less emphasis in understanding what mental health problems are for children and adolescents because so much of the research and the polls have been on adults. So when there started to be a transition to teens and kids, it traditionally focuses on teenagers and then childhood. So like maybe your school age years. So if you're in elementary school, maybe those years. So already there's less information about this particular population in comparison to adults. And then if you pull that back a little bit, there's a lot more information on like middle-aged kids. So again, like 7 to 9, and then adolescents versus infancy and preschoolers in terms of their mental health problems. So it's just a gap in the area of, what our knowledge is about mental health rates. And that doesn't change the fact that preschoolers also experience problems at the same rate as older kids. So again, even though there might be fewer numbers out there, or maybe numbers are lower, that doesn't necessarily mean that kids who are preschoolers aren't also experiencing some sort of behavioral issue or mental health problem. And then these 3 links down here, I'm not going to play them, but I think they're like 1-minute clips, maybe 2-minute clips of some of the issues in mental health problems and why we're starting to see so many issues in young people. Okay, poll for you all. You can put it in the chat or say it out loud. What do you all think? How has COVID influenced the rates of mental health problems in youth? Do you think it's decreased, like gone down? Do you think it's gone up? So COVID was 2020 and kind of carried out a little bit longer. So what do you think has happened since then? Are they staying the same? I wish I could see the chat. You probably can see yourself. Okay, that's okay. Someone says rates have increased. Yeah, definitely increased. Yeah, it seems like the consensus is yes. Rates have increased, and that's exactly true. What do you guys think is the reason for that? So it sounds like everyone feels like, yeah, things have gone up. Mental health problems have worsened for people, whether they're adults or young kids. What are some of the causes of people having more problems in COVID?
I think it has a lot to do with like isolation during that
Mhm.
time.
Yeah, Exactly. Isolation.
I also think that it could have something to do with the fact that it was so hard to seek out like medical intervention during COVID unless it was COVID related.
Hmm.
People just weren't seeking help.
Yeah, like a prioritization of, if, unless this is probably an exaggeration, but unless you're like drastically ill, suffering from COVID, like need to be on ventilation, it seemed that it was much harder or maybe a lot less attention on getting people in everyday care, like going to seek out a therapist or doing other non-COVID things. So, yeah, I think as a society focusing more on COVID, less utilization of services in other areas. I saw another comment that said self-reflection and the boom in social media and technology. Yeah, I think technology, I think there's been a lot, of course, in many years, but in the last 5 years especially, I think resources have been more accessible. If you have like Reddit or like TikTok or Instagram, a lot of many sites combined together when you're isolated. You have a plethora of sites to be looking at. And so, or people sharing their experiences. So yeah, maybe some self-reflection. You don't have very much to do. You're not allowed to go out if you lived in a place where there was like lockdown, right? There were restrictions. So yeah, a lot of time to yourself. And then someone else said, yeah, forced isolation. Yeah, I was exactly. So last person just said homes can definitely have been a toxic environment for some. So I will say for kids, right, one thing, this is across the board, in rates have increased since COVID, but especially if you think about kids who are so have such little say over their environment, where they go. And so everything that you all just said applies to those young kids. So being forced to be at home when we know peer socialization is so important for their development. We know that people need to socialize. It helps like normalize their own behaviors. It helps set a benchmark for how to act with peers. If you were a kid who came from a toxic household or there's some issues at home, let's say your refuge, your safe space is going to school. Maybe there's a teacher you feel really close to. Maybe that teacher was concerned for you and they were going to flag you for the school counselor should go talk to you. You might have lost that resource if you're not able to go to school in person and have this teacher that is looking out for you, really cares about you, can tell because they're an adult that there's something odd going on and maybe the kid doesn't have insight. So just the same, kids have lost a lot of their own resources. And then I think pretty obvious, like 7-year-olds doing like Zoom school is like kind of ridiculous. Like, how does a 7-year-old sit through a 2-hour chunk of time and then go do virtual recess, like, which means get off the computer and go eat a snack or something and then come back. So yeah, it really changed how kids were growing up. Um, and so we can already expect that there's going to be long-term impacts for what that means for them growing up. Now that those kids are probably, if you're like, I don't know, in fourth grade and that was COVID in 2020, it's now 2025 now. So you're probably what, in ninth grade? So you're in high school now. So imagine what that person's life was like growing up in that time. So yeah, rates have increased. I can say just like as a person who sees clients through like a practicum, like the mechanism is really set because it's through our program. Like we're required to see clients. Um, some people go to private practice, some people go to outpatient, some people go to the med center, so TCH, and yeah, also the clinical sites also saw an increase in the number of people that they were able to see once like the COVID restrictions of being able to come back in person came back. So yeah, from the other side, you also saw, yeah, we have a huge wait list. Like unfortunately, we can't even get to everyone because we have so many people seeking out services, which is great. And we also need to be able to serve them all. So yeah, I just wanted to point out it was true for both sides. We saw an increase on the provider side, and we know people experience more mental health problems. So, okay, I'm gonna go back to this. So, okay, age and developmental stage. So, we talked about the 4Ds that need to be accounted for when we're talking about abnormality in children's behavior. And for children and adolescents in particular, we also need to consider the age and the developmental stage they're in order to help us account for is this behavior developmentally appropriate or is it inappropriate? Is it what we can expect based on developmental milestones that we know should occur? So things like that, we need to be able to reflect on some of these basic demographics in order to ask and answer those questions. So the age of onset, so onset is referring to when the problems first present themselves. So when do they first pop up? And so telling yourself or being able to account for when it happened can be really helpful for just thinking backwards and thinking about what might have been the cause. If we don't know the cause, which is often the case, maybe it's helpful to know, oh, it started around this time. So given this person's history, some of these risk factors, it makes a lot of sense that when this thing happened, all of a sudden we saw symptoms officially pop up and manifest themselves in an issue severe enough to need some help. So helps us informing etiology, how severe it is, and then eventually helps us treat it. So if I know someone has been struggling with depression, I'm just going to use that example for a month, that feels very different than someone that I know has been struggling with it since they were 9 years old, and this person is 25 now. So having some sort of sense of how long it's been going on and how severe it is really helpful for conceptualizing what you think is going to work based on treatments that you're going to use. And also, they might have been in therapy already if they have had this issue for a really long time. So also being able to account for they already may know this stuff, or this treatment it may not seem to be jiving with that person. They've already done it. They don't like it. So try something different. um, this next bullet point is important. So for disorders that are typically associated with a later age of onset, when you do see earlier onset for those things that typically happen later, it tends to suggest that there's a more severe course. So for example, seeing substance use disorder or conduct disorder, you're typically going to see this much later in life. You're not going to see substance use disorder for the most part in a 7-year-old. You're expecting that much more in 17-year-old, someone 16, someone in high school getting closer to adulthood. So that's a disorder typically associated with a later age of onset. And so if you use that example of a 17-year-old with a substance use disorder, when you see early onset, so maybe this kid was 7, that would suggest more severe course. So it's a lot more alarming and concerning that this 7-year-old was diagnosed with the substance use disorder. So given that, it might suggest that there's a more severe course to follow after that early age of onset. And then the actual age of onset or the actual onset can occur gradually. So like the examples I just gave, I said, oh, suddenly it popped up at age 10. That's not true in practice. It doesn't necessarily just suddenly show. A lot of times symptoms manifest slowly over time. So you'll maybe see some sadness crop up here and there, but it really isn't until, I don't know, like a month later that you see a lot of symptoms start clustering together. So the actual onset can occur gradually. But that's not to say that, I don't know, some people I've talked to say that, yeah, I woke up the next day and just things felt different. So that would be suggestive of like a sudden onset of symptoms. This graphic is important. It speaks to like what you expect for early versus later onset. And I think I have a couple of questions in the exam about what you would expect for people of different age. So for example, neurodevelopmental disorders, you typically start seeing some symptoms manifest earlier. Doesn't necessarily have to be in birth, but it's why it's up here earlier. And that's also explains why when you have someone who's maybe, I don't know, 15 being referred and maybe they want to be assessed for autism, you're still asking questions about their early milestones and their developmental history, because a lot of times you'll see, ooh, when they were 6 months old, they weren't meeting their milestones. When they were 6 years old, they still were having issues with some socialization. Maybe they don't have peers, things like that. So you can still reflect back and look at here's what I expect, and here's when I think it'll pop up. So we can work backwards to see what happened. Um, the other thing, too, is a lot of these things are related to referral. So hyperactivity, ADHD, a lot of people get referred when they're in school. So yes, parents a lot of the times maybe have a super active kid, in infancy and preschool years. And they might just feel that that's just a super active kid. Like it's a lot of work, it's a handful. Ooh, I'm struggling as a parent, but my kid's just active. Um, it could be that. And then they enter school and the teacher's flagging, ooh, this is like developmentally inappropriate. I have a class of 20 kids and that's like really hyperactive. Like that's out of the norm. And so in that case, the teacher is probably flagging this kid for ADHD problems potentially, and then coming back to the parent and saying, hey, I think it might be worth checking this out. So I think that's also another reason why you see ADHD being talked about a lot in this age area because of the fact that they're entering school. And so their demands are more and they're having to manage, the kid is having to manage like a new setting, new expectations of being in school, a new adult in their life, being a pretty important figure who's their teacher, setting expectations for them. And so, again, this is why a lot of kids start getting referred and treated for ADHD and related disorders pretty early. Okay, I'm gonna move through gender. Just as we were talking about like characteristics that impact what we consider to be normal or abnormal behavior, it also impacts the rates of mental health problems and then the experience of mental health problems. So we know that gender differences do exist for a lot of different psychological disorders, and it's pretty consistent across countries and across times. So in general, and this is, I think, is also on the test for exam one, in general, there's a higher prevalence rate of externalizing disorders for males. So most males tend to get diagnosed with externalizing problems. So things like oppositional defiance disorder, ODD, ADHD, attention deficit hyperactivity disorder. So I can't think of the ratio and right at the top of my head, but there's a pretty like staggering difference. Like you can see there's higher diagnosis rates of like ADHD, for example, in young boys versus young girls. Again, that's not to say that the experience isn't about equal. It might be. It just so happens that I think referral rates matter. Who's referring? Are we accounting for just are there gender norms in the culture? So a lot of these things still factor into why we have these rates. But in general, we tend to see higher rates of externalizing for boys, and lower rates among girls, and then it's flipped for internalizing. So higher rates of internalizing among girls, lower rates among boys. Any questions about that? The table is like an example of some externalizing problems and internalizing problems. Okay.
No.
So, for example, it's not the case that a young male cannot be diagnosed with anorexia, right? An eating disorder. It's just more likely that you'll have in the population higher, like more girls in the population being labeled with that versus males who experience that. So that's an example. The only thing I'll point out is, so again, like I said, all these things factor into why you might have disparities in gender rates. So the self-referral or their gender norms. So all of that is true. And at the same time, in general, it does seem that there are some differences in the experience. So it might actually be the case that there is a gender difference in the actual experience of or lack of experience of certain mental health problems. So this is all just saying, yes, these things are all to be considered. We know that there are these reasons for disparities. And it does seem that in the population, theoretically, there actually might be true gender differences. And it could be related to biological maturity or just difference of experience.
Yeah.
Another question?
Awesome. One double check, thank you.
Don't know if I heard that. Did anyone hear it? I don't know if it was a question. It might just be an accident. Okay. Come back if you have a question. I'm going to move ahead. Stop me if you have another question. Okay, so this is just the end of chapter 1. I am only going to do this in a couple slides. Your textbook probably spends like 4 pages front and back covering this. So I think it's just important to think about where we are in history in terms of how far we've come with the different um, psychological movements to be able to understand where we are in psychology when it comes to kids. So I think a lot of abnormal psych classes will give you just a trajectory, like what happened in history. So early on, many thousands of decades ago, we started off with supernatural theories. So back then, the belief was, and this is like, I don't know, I can't even think of like, it's like 1800s, 1700s, like really, really far out. The belief was that abnormal behavior was derived from issues with supernatural intervention. So back then it was considered that abnormal behavior doesn't just exist. That's odd. It has to do with witchcraft. It's divinity. It's some otherworldly explanation for why they're abnormal behaviors. So again, if you think back to those times, that's why you heard things like like burnings, like lynchings, things like that, because it was thought to be so otherworldly. It's impossible and unfathomable that it's an experience of human nature. It's something beyond us that explains that experience. So supernatural theories prevailed really, really, really early on. Once we started getting more interested in medicine and it became a practice, and then it moved into psychiatry and then psychology, that's when we had a lot of growth for the psychology field, and that's when we started moving into biological theory. So because we have medicine and we're trying to treat physical ailments in the body, the idea was that mental health problems is also caused by some sort of abnormality or breakdown in the body. So there's some somatic cause for mental health problems. So we still think that there's some truth to that, but we have still moved away. It's not that it's all genetics that explains a mental health issue, or it's not just some, I don't know, like my digestion system doesn't work. It's not so simple as saying that that's the cause. So there's some like long-lasting implication of biological theories, but it's not where we are today. Then we moved into psychological theories, and that's where we moved away from just believing that your body has to be the entire cause of mental health problems. And instead we moved into um, actually, there are many different reasons and environmental reasons why mental health problems occur for anybody. And so we started off with psychoanalysis, moved into behaviorism, and then we moved into a cognitive revolution. So the thing to note for kids is that I said this earlier, in general, there wasn't a lot of attention to young kids. People mostly cared about adult well-being, adult physical health, um, because, and I think your textbook talks about this, one, kids were just thought of as the same thing as adults. They're no different than adults. They're literally just little people, which is not true. So that was one line of thought. The other thing is, again, many, many, many years ago, there were high mortality rates for infants and kids. So women were dying during childbirth. Kids were dying of illnesses that they didn't have vaccines for or treatments for. And so back then, if you have fewer kids in your society, there's fewer kids in the population. There's not as much interest on how do we treat mental health or anything in kids. So that explains why traditionally there's not a lot of, or there wasn't a lot of focus or care for young kids. And then that shifted over time as we started getting more like sophisticated or advanced in our understanding of just psychology as a whole. Just curious, because I won't have to spend a lot of time on this, but how many of you all are like familiar with psychoanalysis, behaviorism, and like the cognitive revolution? I can skip it if it seems like most people are familiar. I see a couple hands. Do the hands mean yes, familiar? I think so. Can someone tell me if I'm correct that I think the hands mean you do know about it?
Yes,
That's
it's
what it
familiar.
is.
Yeah.
Okay, okay. That's what I thought. I know most of you are all like seniors or juniors. Okay, I'm gonna skip this. Just in the future, like just take a look at it. I think the main thing I want you to know is just psychoanalysis, important for finally telling us that childhood matters, right? Granted, there's a lot of controversy and things that we don't do today for most psychologists. So a lot of us don't do things like dream analysis. We don't have you sit on a couch and put your back to us and just free associate. But there's still a lot of implication for today. So number one, for abnormal child psychology, it was like the first modern attempt at saying, actually, childhood matters. Again, they believed that um, it was like unresolved conflict, typically driven by sexual desire in your childhood, that then, like bleeds into having mental health problems. Most of us today don't think that, but I think, again, what we can take as the kernel of truth from there is, oh, childhood matters. Childhood experiences do impact and explain some things in adulthood. So I think that's the biggest takeaway from psychoanalysis, beyond the fact there are controversies about id, ego, superego, all of that stuff. And most psychoanalysts today are not like the traditional ones you would think of. Again, they're not the ones who free associate and talk about like Oedipus complex and stuff like that. The way it is mostly talked about today as modern psychoanalysts are people who just emphasize like the more dynamic representational stuff that happens in these relationships. So most people are not doing traditional psychoanalysis. If you call yourself someone who has roots in psychodynamic theory, it's typically something that's on this slide. So you guys can always refer to this. Behaviorism, I'm going to skip that. Just know that we moved away from unconscious representational things to now saying we should be able to observe and witness and be able to train anything that we're seeing when it comes to behavior. So that comes into play for kids because that tells us that the environment is important. I know that if you observe someone else or your parent or whatever, in Pavlov's example, like if you train something or you're classically conditioning it or operantly using conditioning, that has an impact on behavior. So we care about that today because principles of behaviorism are used to treat certain disorders. And we also recognize that is social learning that takes place when it comes to observation. So little kids are like little sponges. They observe everything in their environment. And so it's not surprising that we see implications for adulthood. And then the cognitive revolution, we moved away from just saying it has to be behavior, it has to be observed. Now we're saying it's thought that has an implication for mental health problems. It's how you think about stuff. It's your representation of the world. It's your schema. It's how you understand something to have happened that matters. And so this is important because it impacts specific types of therapy treatment for certain mental health problems. So then this is the last slide from chapter 1. Basically, all that matters here is that when it comes to children in particular, there was a movement to move away from institutionalization. So not just kids, but most people who had mental health problems at this stage in history were put in custodial care, like asylums. And there was not great treatment in these institutions. And so, this mental hygiene movement just moved to take people outside of these institutions and treat them with respect and care and actually try to treat these problems. So that's the history. And then clinical practice. It sounds like most of you are familiar with this, but there are many different professions that work with kids, whether you're a psychologist of a doctoral degree, whether or not you're a physician. So maybe you're a ND or your DO, your PA, someone who's working physically or medically with the child. Therapists are people who work with kids, teachers, and of course, many other professions. So with that being said, that means that there are really unique ethics when it comes to working with kids, because we have to consider, we need to be able, let's say you're the therapist for a young kid, even though we're the adult and they're the kid, there's mutual respect. We're equal in this relationship. And at the same time, as an adult, as a clinician, I still have to abide by specific ethical codes. So if you tell me, the 7-year-old, that you are suicidal and I'm concerned for you, although there's respect and there's confidentiality in this relationship, it's still my responsibility and my obligation to inform your parent if I'm concerned with your safety or safety of others. So it's important to remember that like you're working really hard to align with the kids. develop some rapport, like bring yourself down to their level so they think you're someone that they can talk to. And at the same time, know that there are regulations. You have mandated reporting. You have to report if you suspect abuse to the child, if you suspect elderly abuse. Um, so there's different, you know, re- reporting requirements that take place. And so it's your responsibility to build alliance with your kid and early on also communicate the exceptions to confidentiality. So if I'm worried about your safety, unfortunately that means I have to share with your parent. And the only reason is not to like rat you out, it's because I care about you. It's because I want to make a plan to make sure we're all safe. And I'm an adult, so I have a responsibility to tell your adult in your life that we have to work together to keep you safe. So mandated reporting is something to consider, and the right to confidentiality with those exceptions. And the other thing, and I think I have a question on this in the first exam, is informed consent. So consent with the C is obtained from an adult, a legal guardian, a parent. You have to obtain informed consent when it comes to therapy, clinical practice. You should discuss confidentiality and all these things with the kid, but the child themselves is not actually giving consent. So it is important to talk them through everything that's, required of you when it comes to mandated reporting, tell them that you have a relationship, you want them to share with you, but you're not actually obtaining formal consent procedure. So typically we would say assent, ASSENT for kids, but in clinical practice, we actually only need legal consent from the adult. In research, that's different. So in research, we do actually obtain assent from the teen or child and consent from the adult, unless there's a particular reason why we wouldn't actually ask for assent. So we would actually we err in research on the side of assent/consent for everybody, unless there's some special circumstance, versus clinical work, which is just, I only need the legal guardian to give me consent to do therapy with this child. And then, of course, if the child's like resistant, doesn't want to do therapy with you, and you're getting nowhere, then that's a different story. But that's not an issue of consent/assent. That's just, is the child engaged? And it might be because this teenager didn't provide their own assent. Their parent made them do therapy, did their consent for them. That does impact whether or not they're invested or not. So legally, we just need consent in the clinical world. But that's not to say that whether or not they want to participate, whether or not they want to be there, doesn't make some sort of like implication in your therapy work. Okay, I still see hands from the first question. Any questions about this? You can ignore this slide because I'm going to show you another thing before we move on. No? Okay, so this was just wrapping up chapter 1 that I was hoping to get through on Monday. You are here, attend class on Wednesday, that's this. The one thing, I don't know if some of you have done this already, but if you've read the syllabus, which I hope you have, you'll know that there was an optional syllabus quiz for extra credit. And so there's up to 10 extra credit points, so 1 point for every question you get right. It's open and it stays open until I think the Monday after the withdrawal date. So the dates are on Canvas, but it's open if you wanted to get extra credit. Okay, any questions before I open this other slide? We have like 12 minutes.
I do want to ask you something, but it has
Mhm.
nothing to do with the reading. So for work, I start like a training in next week, and it's gonna last until like February. Is there any like, is that okay if I don't like see like the live classes, but I see the recordings of it for the next upcoming weeks?
Yeah, thanks for asking that. Yeah, so that's fine. I think if there are like specific things in your life that I have to attend, that's fine. Just watch the live recording or whatever I record and then make sure you're keeping up. Um, I will say that just means that, to be honest, I haven't planned the days that I'm doing like the special code word, so I can't say when those will be. So the only difference is just I may or may not give a code word in those days, but I think it's okay. I think you'll be okay.
Okay, sounds good. Yeah, sorry, I work from home, but
Yeah.
this training requires me to be on camera, so it's like they will watch me if I'm like in the middle
They'll
of
flag
class.
you. Yeah.
Yeah.
No, thanks. So that's okay. And thank you for telling me. I also had someone email me after class last week. I'm not a hard ass, I promise. I just tell me and I'm totally fine with it. So just let me know this was great. Yeah, and you'll be totally fine. No
Thank you,
issue.
appreciate it.
Mm-hmm. Okay, we have 11 minutes. I'm gonna start talking about chapter 2/chapter 3, which is, I think, a very important topic because it informs how we think about like the conceptualization for child psychology, and it has relevance for your first assignment, which isn't due for another like I don't know, like a month. Like there's a lot of time, but this is the PowerPoint that you're going to want to refer back to. So I'm going to see how far we get. And then whatever we don't do today just means that on Friday, so in 2 days, for the flipped classroom, just remember we're not actually meeting. And so that just means read the rest of this lecture, like review it, and then you can look at the recordings. I have a slide on this too, so I can share that. Okay. Okay, I'm assuming you can see the slides. Okay. So chapter 2, I decided to in your syllabus combine chapter 2 and chapter 3. And that's because in general, I want the overall domain for you all to think back on is developmental psychopathology. And these 2 chapters, I think, are helpful for understanding the different pieces of developmental psychopathology. Um, I just saw a hand go up. Should I stop and answer your question? Or is that an accident or from before? Okay, I'm gonna move on, unless you saw me. This is what I was just saying. On Friday, we have a flipped classroom. I will still have office hours, excuse me, at 10 o'clock. I just won't be available from 9 to 10 during our normal lecture time. So it just means, again, look at the lecture slides, watch last year's recording, which I will share with you. And then just think of any questions if you have any. The next class that we do have, I'll just open up by saying, like, do you have any questions from last Friday when we did not meet? So just keep that in mind. And then Monday, so Friday we're having flipped classroom, and then Monday we have no class because it's MLK Day. It's a holiday, so we are not meeting, which means our next class is actually a week from now on Wednesday. So we're not meeting for 2 class periods. One of them is a holiday, one of them is flipped classroom. We will see each other in a week. Any questions about that?
Hi, I had a question.
Yeah,
Sorry,
that's
it's
okay.
not about this.
Uh-huh.
I'm not able to see chapter two's PowerPoint. It
Hmm.
keeps telling me it's like hidden or like blocked. I can see the chapter 2 to 3,
Okay.
the biological and environmental
Mhm.
context, but I can't see the one you have up. Sorry about
Is
that.
no, that's okay. Is that on Canvas? Or you mean right now what I'm sharing?
Yes, it's on Canvas.
Okay, I'll check that. It might just be I don't know why it's hidden. So I'll fix that so that you can see everything. So it'll be this PowerPoint chapter 2 and then like the one that you can see, the one that says 2/3.
Okay, thank you.
Yeah, I'll do that after class. Any other questions? Okay, I'm gonna move on. So the theme for the next week is developmental psychopathology. It covers chapter 2 and 3. We're gonna see how far we get, and then the rest is for you guys to do on Friday. So, honestly, I'm not gonna spend a lot of time on this slide. Your textbook focuses on it. I don't think it's worth a lot of discussion. I think the thing to know here when it comes to theory and therapy is that the theory, there are many different theories. There's attachment theory, there's developmental theories. So like Eric Erickson, who is like a developmental psychologist. A lot of influential people in psychology have had some sort of theory. And so those are just a set of ideas that guides our reflection or how we think about something. When it comes to psychology, we care about theory because that might help explain why a mental health problem is occurring, what maintains it, and then how to treat it. So theory is important because it's not just about clinical practice. What do I see in the clinic? Who am I working with? To be a psychologist, if you're going to be a psychologist, and also if you're going to be just any other clinician, whether it's an LPC, MSW, whatever you're doing, you're going to always want to keep your theory in mind. So in a PhD program, for example, we spend a lot of time thinking about theory, research, and how does that combine with clinical work? Because I always want to make sure I'm doing something that's evidence-based with my clients. So having some sort of theory or framework in mind is super helpful, and it helps you justify what you're doing. If you have a parent ask you, yeah, I heard you give this recommendation, like why? That doesn't make sense to me. Then you can say, like, I'm conceptualizing this case from this sort of like theory or standpoint. And you would say, like, there's a lot of evidence for this. This is the evidence-based treatment. And so this is why I'm suggesting it. This is how I'm thinking about your case. So theory is important for how you're conceptualizing and then for what intervention or therapy modality you're using. So that's super important. There are different types of theoretical models. So for psychology and psychopathology, why that matters is because depending on the model you're using, that might impact how you consider certain settings as being important for your person that you're conceptualizing. So interactional models basically tell us that different environments and your person of interest. So these variables interact with one another. So an example of an interactional model is one you've probably heard, which is the diathesis stress model. So the diathesis is some sort of like underlying vulnerability that just you have, what's something you're born with. It is what it is. It's your vulnerability. That's your diathesis. And then when you come in contact with some stressor, so let's say I have this vulnerability factor of, I don't know, like I have family history of depression. So that's my diathesis. And I come across a stressor, let's say I just started middle school, my life just changed. I was homeschooled and now I'm in public school. That's a huge stressor. There's new people. I don't have any friends. That stress interacts with your vulnerability, which then equals whatever depressive symptoms you're experiencing. So interactional models are important because that just tells us that we don't live in isolation. It's not just that you live with some sort of vulnerability and it never interacts with anything in your life. It means that things interact with each other. So we can see how different things always have some sort of like impact on us. Another one is transactional models, which goes beyond interactional. So now it's saying that whatever systems you are in, it's not just that one acts on top of another, it's that they interact with each other, they transact with one another. So there's active, ongoing, reciprocal interaction between the individual and the environment. So this falls under the broader systems model, which just means there are theoretical systems that come into play. So I might think about in Brofenbrenner's on the right, which is an ecological model. I think of my kid, the individual inside, and I know that in a systems framework, they live embedded with multiple systems. So they live within the system of their immediate family, of their community, of the city that they live in, and then the broader like country. So that's a system, which is why it's a systems model, and it's still transactional because the child interacts with each of these systems, and that system interacts back with them. So if I'm thinking about a kid and this immediate family in the pink circle, I know that it's transactional because the child interacts with, let's say, mom, right? There's some interaction going on. Mom is part of this other system of the family, and then however child acts impacts how the mom then interacts back with the child. So there's some sort of interaction going on, and then it just kind of plays off of each other. That's no different from the child interacting with the teacher from the purple circle. So these are just important models to think about. Because this is how we'll think about what are certain risk factors and protective factors in that child's life. Those risk and protective factors will probably come from these other settings that they're interacting with, or it might be their own biological vulnerabilities or their own social protective factors that are in that child's life if we were to use the biopsychosocial model. Okay, I'm looking at time. We have 1 minute, unless you want to stay. You don't have to. I think what I'm gonna do, because I think it is recording, is I'm just gonna review this in my office hours. I think what's important for you all to do, because I won't see you Friday or Monday, is just make sure you're reading the rest of this PowerPoint. there's like first half is just talking about what is developmental psychopathology. There's a bunch of different principles. So I'm going to outline like these are the things that are stated in developmental psychopathology. And then at the very end, there's like you'll see like a picture with like a purple like text box. So it's basically a conceptual model using developmental psychopathology. I probably won't review that. I might just revisit it next week when we meet. It's important because it teaches you how to use a conceptual model when we're talking about a particular kid, and you're basically doing that for assignment 1. So I think that's important. So you're just reading this on your own, basically on Friday and on Monday. I'm going to stop this here. If you have any questions. Yeah, will I be posting the second chapter on Canvas today? So whoever reminded me, I need to check and make sure both of the things are up there. And then you guys should be able to see 2 PowerPoints. So one PowerPoint is the one I'm reviewing right now, and it's called just chapter 2. And then I'm going to upload another one, which is the rest of chapter 2, and it's all of chapter 3. So you basically have 2 PowerPoints to look at. And I'll do that today, probably during office hours. Any other questions? Do you feel like you know what you're doing? Like we're not meeting on Friday or Monday? Yeah, okay. All right. You can all head out. I'm going to keep this up unless anyone wants to talk about this during office hours.
Thank you. Have a
Thank
good day.
you.
Have a good weekend.
Bye.
Bye. Will I do secret code during office hours? No, that's not fair. No, I won't. You're not required to go to office hours. Okay, stopping recording.